that we're discussing which is just COVID-19 testing.
Can I please ask everybody to mute their phones, please? Please mute your phones except Dr. Leila.
Okay.
Thank you very much.
Thank you. We'll talk a little bit about this of the virus, and then in broad terms, the classification of tests that are available for us to diagnose SARS-CoV-2 infection, which is basically the PCR and serology. And I will try to quickly go over the pros and cons of each of them. So the virus itself is a beta chorus subgenus virus. It's a stranded RNA virus, and the RNA of that virus is kind of packaged or covered by this nucleic acid. The viral RNA nucleocapsid is then embraced with this lipid envelope, and then this lipid has several proteins. The very important one is the spike protein, which is an protein for the entry of the virus inside the host. Also have the protein, and we also have the membrane. So these aren't things to remember because they constitute targets, and I will talk about later on. So in terms of the species, again, so to the beta viruses, and there are three lineage A, B, and C. So it is in the lineage B, has a very close relationship to the SARS-CoV, but it also has a linkage to other coronavirus that are causing common cold, like 43 and HQU1. This also has a closer relationship with the MERS-CoV viruses. The significance of that is it's important to remember because of the cross-reactivity between the virus and the detection method between the virus, SARS-CoV-2, and these other common coronaviruses as well. In terms of the gene structure of the SARS-CoV virus, it can be divided into big groups or two big regions. Basically, the region which is responsible for the viral application, so the RNA-dependent polymerase, and the most important genes there is the reading frame, the ORF1A and 1B. And then the rest of the genome of the virus are for producing the structural proteins of the virus, so spike protein, the envelope, and the nucleocapsid protein. So again, the importance of that you have to remember, there are four particular targets that we can use to detect this virus, and the most ones really are the RFA. So this is the RNA-dependent RNA polymerase. There is the S gene, the E gene, and the N gene. There are two main antigenic targets, which antibodies can be developed, so again, to detect immunity or to detect seroconversion. So you can have antibodies that are, again, the S antigen, either the S1 and S2 combined, or S1 and the receptor binding, or towards the nucleocapsid, the basically the N antigen. The N antigen can be more conserved amongst the coronaviruses and more abundant. So more assays are available directly towards the N antigen. So these are antibodies basically detecting the N antibodies, I should say. However, the S antibodies are the ones hoping when we get the vaccine. These are the antibodies that neutralize the virus as well. So tests for SARS-CoV-2 can be broadly classified into two main groups, either the virus detection itself, and that is mainly for acute infection, antibody detection, which is for response. Now, the vaccination, there are several methods available. But the most popular one and the gold standard really is the RT-PCR. But there are also other methods like the thermal amplification, the CRISPR technology. There are some antigen detection are now available and FDA approved. The sensitivity of these are not very good. Some of them are specific. There are viral cultures and sequencing also are methods, but they are only available in research setting. In terms of the antibody detection, again, you can classify them broadly into two big categories, either binding antibody detection methods or neutralizing antibody detection method. And Dr. Jihan is going to talk to us further about neutralizing antibodies and their role as well in the COVID infection. The binding antibody detection, you can have the classic point of care, what I call the pregnancy test kind of assay, so the lateral flow, or the ELISA base, or the immunoluminescence, or basically the immune assays. The neutralization antibody assays are classified into viral neutralizing test or super-neutralizing test. The viral neutralizing test actually depends on antibodies that are neutralizing culture, so living virus. You can imagine these are done in very, very specialized BLS3 laboratories. So the virus detection and antibody detection should not be considered as alternatives. They are complementing each other, really, but they're not alternatives to each other. The RT-PCR is still the gold for the diagnosis, and it is the one recommended by CDC and the WHO. And the diagnostic window for the RT-PCR is about 3 to 14 days from the infection. So here's just a diagram straight. So basically, the viral, the viral RNA, you start picking that up by day 3, and then you continue to pick it up. Week 1 is the most, we get really almost all of it, and then the viral titers, if you will, decrease a little bit. So by week 3, more or less, most people will clear the virus. This will coincide with the development of the antibodies. Now, with the SARS-CoV, and really IgM and IgG more come about the same time. In fact, sometimes the IgM may lag a little behind IgG in some studies. Not a huge difference between the IgG and seroconversion. Antibodies classically will start by week 2, and then by week 3 you can detect them in all patients who got infected. In terms of the RT-PCR assays, different types and configurations of it. The traditional, which you have to have an extraction step and the amplification and then detection step. So these are the ones that we have in some labs, and this a little bit time consuming, but it's a very, very good assay. And then, there are the quick creation assays in which either the amplification is summarized, or where you have extraction and detection all happening at the same time. Things like, Gene Expert and these really help because they can speed up the of the virus. Reporting, there are 4 terminologies that everybody agreed to use. You either detect the virus, and basically when detected, it means that you're detecting virus more than the limit of detection of the assay, or it's not detected, which is less than the detection of the assay. And then the presumptive, previously we used to call it conclusive, and I will explain this in a minute, or an invalid result. So the terminologies, what happened here in the UAE is the National Committee for Emergencies and Disasters have kind of, there is a COVID testing task force, and they hit on certain terminology. So remember, I told you about the genes that we target, and and in the different assays and configurations. And basically, if you detect at least 2 of these genes, then you can report the virus as detected. Now, there is one important gene, which is the ORFNB. If you detect that one, even when an E genes were negative, your internal control and everything else is working, you can still report this as detected. It's a very specific gene, as I mentioned before. Now, the presumptive positive comes if you only have the E gene, for example, reacting, or you're getting only in the E gene, but the N gene and the ORFA and B are amplifying, or you get only amplification in the E gene. So one of these is amplifying, but not the others. Then you call this a presumptive positive. In this case, what you want to do, because you're not really sure, an infection which is kind of fading away, or this is an early infection, what I like to do then is to repeat test within 8 to 72 hours to see if the patient is really kind of clearing the, most probably the test is going to become negative, and then that's fine. If in fact it was early on in the infection, then you may be able to pick up other virus or other genes, and in this case it's positive. If it remains, then you would still call it as well. An invalid result is we do not have any reaction at all in the PCR reaction, and we have internal control tell us that the reaction works, and we also have the positive controls. And when these are not working, you know that there is an inhibitor in this sample that basically inhibited the reaction. So this is an invalid sort of result. The opposite is also true. If you have a contamination, thing is lighting up, everything is positive, including your negative control, is also an invalid run. So these, this is an invalid and lab-related issue, or a contamination, or an inhibitor in the specimen. So this is again the explanation of inconclusive, so the presence of 1 out of the 3 genes as positive, and it also can happen with, as I mentioned to you, with either early on in the infection or later on. Now, questions that I have been getting day and night, every day, about the false negatives, positives, and why that is. So false negatives can happen with the RT-PCR method for the detection of the SARS-CoV-2 virus. And you can again classify them into pre-analytic, post-analytic, but the factors, the collection, whether you're using an NP swab or a pharyngeal swab. So the nasopharyngeal swabs are they have more viral yield, and they're sensitive, obviously, than the oropharyngeal swab. People are talking about saliva. Now, if you use deeper specimens like sputum or bronchial lavages, you get a better yield of virus. A UT compatibility, sometimes if the medium that you're using to transport or the swabs, if it's not very good, it could actually not produce the virus. Time in relation to infection, so very early or very late in the infection, when the viral is not very high, you may that, or it may call it a negative. In fact, there is still some virus. Specimen processing, if it wasn't transported or processed appropriately, and then the limit action of the assay, or the analytic sensitivity. So you have assays of detection of 10 copies per ml, and other assays 250 copies per ml. So there are definitely a difference in the limit of sensitivity of these assays. So if you go to lab A with the 10 copies per ml, this lab may call you positive. If you go lab B with the 250 copies per ml, you actually may test negative. It's very low viral load. False positive, luckily, we're facing this, then the false negatives. And sometimes it may indicate either a pre-analytic or analytic contamination. What we also experience in our labs is that some certain assays actually have a late amplification. So what happens is we actually enter what we call the cycle threshold value. So with the polymerase interaction, you have cycles of amplification, and you're monitoring to see with each repeated cycle when you will detect the signal virals. Class, by cycle 20, 25, you may detect something, and most have a cutoff up to cycle 30, for example. So anything amplifying up to cycle 38 is considered positive, and anything after that is negative. Certain assays can go beyond 38 cycles, and
to complete their full name, email, etc.
Can you please, could everybody please mute that?
Thank you. So these instruments that are detecting those cycles, it can sometimes give you, again, what we call, it's not really false positive, but it's rather a late amplification. So it picks up something, say cycle 42, analyzer that stops at cycle 38, all this negative, but an analyzer that all the way up to cycle 45 for it may call something amplifying at cycle 2 as positive, and hence the confusion again. And is this a false positive? What is that? Again, we classically see these phenomenon in people who are clearing virus. So these are people who are still virus, but it lingers, the virus stay with them a little bit. Among some of our caregivers, we don't understand what is that. The other people also observe this. When they culture the virus, that they find any viable virus. These are people that are shedding beyond 3 weeks. Also due to incompatibilities, again, either between UTM and the extraction, or between extraction and amplification. And false positives are more likely when the prevalence of the disease is low. Just an illustration again to demonstrate that by week 1, really the activity of the RC-PCR is almost perfect, and then it decreases. Say maybe week 4 is 2, by week 6 really is deep. Moving on to serology, so there is an array of serological tests available to us, and they are either detecting IgG or IgM, or what we call the total, which is IgM together, or they could be as targeting the nucleocapsid antibodies, the spike antibodies, ELISA, there is chemiluminescence, so we have a different hybrid. Most of them are qualitative in nature, but some quantitative assays as well. So this is just examples of an ELISA platform, and this is the lateral flow or the point of care kind of assays. Some facts about serology, as I mentioned before, is antibodies stop, after 2 weeks of infection. More certainly by days so after 3 weeks you will really detect them. Total antibodies appear 2 days earlier than the IgG isotype, so maybe a little bit positive. There is no role of detecting IgA in serum per se, so assays detecting IgA have no role to play in this particular disease. And there are 3 strategies really to optimize testing outcome when you're using serology. These were recommended by the CDC in their interim guidelines. The first thing, you choose a test with high specificity, so you really need a very specific specificity greater than 99.5%. Focus on individuals with high pretest probability, so your high-risk groups likely to be exposed or having the infection. And then what we call the orthogonal testing algorithm, or the 2-step testing, and I'll explain that in a minute. If you have 2 tests, for example, let us say an assay that looks at this antibody and an assay that looks at the antibodies, or one looks at the IgG specific, and say test number 1 is a study of 97 and specificity of 3. If you have a prevalence of the condition about 5%, then the possibility of this test alone is about 52%, i.e., if you test on this platform and you test it, the chances of you actually, the chances of this being a real positive, and if you actually having antibodies towards is about 42%. Now, if you test it on the other platform well, and you test it again, and if you combine these two, then really the possibility of value increases from 42% to 94%. So this the two-step process is about. And here is just, again, I took this from the guidelines. It just shows you the importance, and really the importance is that with when the prevalence of the disease is low, it really is to apply the two tests to improve your value. As you can see, as this increases, then pretty much you can actually apply a test if you like, if it has a decent specificity. In terms of applications, so serology have several applications. One of them is obviously clinical in nature, which is to support the diagnosis of illness in late presenters. So these people who present later on in the infection, after 9 to 14 days, negative RT-PCR, classic picture, CT scan, whatever, and you want to confirm this is really COVID related or not. If antibody comes back positive, that could definitely help. In children presenting with a multi-system hyperinflammatory syndrome, because again, classically, these kids tend to later on in the course of the disease or in the course of infection, we're usually not able to detect the virus by the RT-PCR anymore. It also plays an important role in selecting donors for the convalescent plasma therapy. So it's advisable to test donors before you take their plasma to see the antibodies. The huge role also is the epidemiology of the disease and the seroprevalence in the community. It's very, very important to calculate true case fatality and so on when you do the seroprevalence in a given community, and also contact tracing. There are potential applications with occupational health as well, again amongst the higher risk group. And then, of course, when the vaccine becomes available to test the vaccination response, or who should take it, who shouldn't, and many nations when it comes to research. Limitations, or one has to remember about immunology, again, is that the immunological correlate of immunity is not fine. So yes, you're detecting those antibodies. Yes, the individual has serum and they have antibodies towards SARS-CoV virus, but does that mean that this individual is immune? We still don't know yet. However, the initial data or indicators to indicate yes, maybe these provide protection. And basically seen in China so far. There were some experiments that were done on primates where the infected antibodies were developed. They re-challenged those, and they did not do the reinfection again. And then obviously we are in the convalescent plasma antibodies to try to help us. But still, having said that, have studies to actually exactly that yes, you do get immunity if you develop those antibodies. And we have so many things. What is the level of antibody required for this immunity if you were to get it? How long does it last? Is it a couple of months, 1 week, 2 years? The kinetics of the antibody response, and then the correlation between antibodies to the neutralization, and Dr. Jihad is going to talk about this point in a very elaborate manner. Other indications is you have to remember, I talked to you about the other coronaviruses, so they could get some cross-reactivity with these, could lead to a false positive result. You can also get a false negative early on in disease, or patients who are immunocompromised, who are to mount an immune response deficient or on biological agents or presence. So this is why it is recommended to use some interpretive comments when reporting whether a negative result or a positive. So basically, again, with the negative results, to remind people that you rely on this, that, oh, okay, your answer is negative, you don't have COVID. No, you have to do the RT-PCR to confirm whether or not somebody has COVID, serology. And then with the positive results, you cannot just say, oh, great, your antibody is positive, you're probably immune. Sorry, but we cannot really confirm that yet. So a caution about the fact that this could also be a false positive result. And this is when I say before, you do two-step assays. There are clearly things that I don't do right now as far as serology is concerned. So serological should not be used to diagnose a COVID-19 infection. Again, the RT-PCR is the gold standard here and it's the mainstay. It should not be used to make decisions about group. So you say, oh, all these people are having antibody positive, they can live together, or they can all work together, or they should not use that at this point in time, or to make decisions about return to work, to change your PPEs at all, or PPE guidelines. You should not use antibodies to do that. And lastly, you should not use it to immunity passports until and more the durability, immunity of these antibodies. A lot of research applications are out there, and as I said again, the immunological value of it is very important. But there are many answered questions that are right now being researched by active researchers. I was really privileged to be part of a group work together here, the National Committee for Emergency Preparedness, to develop the COVID-19 guidelines on the serologic test, and we came up with several recommendations, which I just shared with you earlier, the highlights, and these were the members of this committee. And so in some closing then, again, I'll list that the RT-PCR is the gold standard used for the diagnosis of acute infection. I hope I gave you a flavor of the various pitfalls, how we interpret them, what does the result interpretation actually mean. The biological antibody assays can help in the detection of late COVID-19 infection when the RT-PCR is expected to be negative in seroprevalence studies and in contact tracings, and have some role to play in AUG health. They can be to certainly determine the eligibility to plasma donation for patients who recovered from COVID-19 disease. It is of great value in the epidemiological studies of the COVID pandemic. So with that, I'd like to close, and I thank you very much for your attention.
Thank you very much, Dr. Layla. Another very interesting and very informative talk. In terms of, if I may again, because we're running very late in terms of the overall program and trying to stick to the program, a couple of questions. I'll give the first question to Dr. Afroz. Go ahead, Dr. Afroz.
Thank you, Dr. Khan. Thank you. I appreciate that. Dr. Layla, assalamu alaikum.
Assalamu alaikum. How are you?
Nice to see you again. Yeah. My question is, when the sample is coming for COVID-19 testing, what other markers that are supposed to be important to test in the serum or plasma of these patients?
So There are various, actually, we have a panel of tests that we use for patients patients with a diagnosis of COVID-19. We look at their functions, at their kidney functions. We actually look at their lymphocyte count and unit count as well. We obviously as their D-dimer concentrations, C-reactive proteins. If that is elevated, we may also reflect to the IL-6 as well. We also monitor in cases the high sensitivity troponin, if they're a certain age or if they are with cardiac symptoms. And we also look at the triglycerides because some abnormalities there as well. I tried to squeeze in the vitamin D as well in the evaluation of these patients, and my colleagues as well agree. And in fact, they are using this as well as probiotics as well for treatment of these patients.
So this is measured in all patients or selective patients, these markers that you mentioned, Dr. Laila?
Most of them will get of these tests upon it. The cardiac markers are in selected groups, but most of them get that basic. And the IL-6 is only done if the CRP is increasing, and then we also add acetone as well to see if there's any bacterial infection happening.
There is one important point, Dr. Laila, asking this question because no data is published from anywhere in the world about the COVID-19 testing with these parameters or markers that you mentioned. And if there is a data with you, it can be easily published in BMJ. Okay, we got a publication in BMJ just last month, but now I'm keeping an eye on all the publications coming out of COVID-19. They don't have these markers. This is a very, very important information. And if you have maybe 200 patients, 100 patients, it can be published easily.
Sure.
Thank you.
Sure, and yeah, thank you. And we have some publications from China as well, shed some light on these, especially the role of the G-dimers and yes. Thank you, Dr. Han.
Dr. Laila, can I just one pending question, just one question, very short question.
Sure.
We have, in terms of positivity for COVID-19, not only do we get positivity prior to the symptomology, asymptomatic patients, we get positive, but also importantly, and to some extent worryingly, which you alluded to in your talk, we get positivity post symptoms. So patient has been cleared, no symptoms, 2, 3, 4 weeks after the patient has been cleared the disease, no symptomology, the test starts still coming up positive. The question there is that how are these patients infectious and are they worrying? I know by culture, some of these viruses, the patients do not seem to show culture positivity, which implies that they're non-infectious. What's your take on that? Should people be worried if that sample, if they're positive tests 3, 4, 5 weeks after the initial positivity, they're still coming up positive?
So that's an excellent question, Dr. Khan, and that was one of the questions I always got. And we tend to see, especially in the elderly patients, the virus lingers sometimes, and some not necessarily elderly, healthy caregivers who have absolute symptoms, but they continue to shed the virus on 2 weeks, beyond 3 weeks some as well. And they're completely asymptomatic. So, you know, what we end up doing is we end up actually examining. So remember I talked to you about the cycle threshold. And in those patients, you can see that it is really the late amplification. It really comes at, cycle 37 or, almost just before the threshold. And we decided then to come up with a comment saying, you know what, it is positive, but it's really a late amplification, and that could indicate that you are clearing the virus. We also do antibody tests on these patients, and if their antibodies test is positive, it also gives another layer of reassurance. However, in the absence of culture, you cannot really confirm 100% that they are not infective. Although, to your point, the studies that have looked at these patients and cultured the virus, they find any viable virus detected, beyond 2 weeks in those patients. So, but unless this, you cannot just give assurances that, yeah, you can come to work, unless we know a little bit more better, and hopefully maybe serology can help with that. If the serology is positive, then this individual now is immune, and then the individual come back to work and it's not infected. We cannot recommend that. So right now, tell them to still stay until they have their 2 negative CPCRs.
Thank you very much. Thank you very much. We have to move on. Thank you very much, Dr. Layla.
Thank you.
Our next speaker is Dr. Jihad Al-Ghazali. Dr. Jihad is a consultant immunologist and chief of the immunology section at Sheikh Khalifa Medical City. He joined Sheikh Khalifa after having worked prior to that in King Fahd Medical Center in Riyadh, where he was also a professor of clinical immunology and consultant immunologist. He is an MD and a PhD and board certified in clinical and laboratory immunology, both from Sweden and US. He's an established researcher with more than 70 publications in international journals. His main research interests are in immunopathology, infection and immunity, molecular genetics, and molecular basis of disease. Dr. Jihad is a fantastic speaker. I heard him talk a number of times before. Dr. Jihad, it's a pleasure to see you again. The floor is yours.
Assalamu alaikum, Dr. Khan. Thank you very much for the introduction, Professor.
Take care.
Today, I'm going to talk to you about the role of antibodies in COVID-19. Just 1 minute, please. I think there is a problem in moving the slides. The ongoing outbreak of COVID-19, and the abbreviation is for COVID-19 is coronavirus infectious disease 19. It is caused by a novel virus we abbreviated as SARS-CoV-2, or severe acute respiratory syndrome coronavirus 2. And I mentioned the first statement because there is a lot of confusions. When we are in discussions, some people, they tell you that this patient has COVID-19, or this patient is infected with COVID-19. The patient is not infected with COVID-19, but the patient is infected by the virus. And the virus, it is called SARS-CoV-2, or severe acute respiratory syndrome coronavirus 2. The virus, or SARS-CoV-2, it is an enveloped positive stranded RNA virus. And the virus has 4 major structural proteins on its surface. That includes the S-spike antigen, the envelope E, the membrane M, and the nucleocapsid N. This is in addition to other 16 non-structural proteins. Their number is between 1 to 16. This is in addition to like 5 to 8 accessory proteins. And when we talk about SARS-CoV-2 immunogenicity, we talk about the antigens on the surface of the virus that are immunogenic. Immunogenic means they trigger an immune response. And among the surface antigens on the surface of the virus, there are 2 immunogenic antigens, the S-spike antigen and the N-nucleocapsid antigen. The S-spike antigen or protein, plays an essential role in viral attachment, fusion, and entry and transmission of the virus. And it has two subunits, the S1 subunit and the S2 subunits. The S1 subunit is responsible for the virus receptor binding. And the S2 subunit is responsible for the virus cell membrane fusion. And it is worth mentioning that the S1, it has two domains. The S1 antigen, it has a receptor binding domain, and I'm going to refer to in the text as RBD, and the N-terminal domain. And the virus, or what I'm referring to, the receptor binding domain, it binds to the ACE2 enzyme, which is the angiotensin converting enzyme 2, which acts as a surface of certain host cells. And the virus, it binds to the AC receptor on several cells in the body, especially pneumocytes in the lungs, and in particularly type 2 alveolar cells, or we abbreviate them as ATE2 cells, and the upper esophagus and stratified epithelial cells. And there are other sites that express also the ACE receptor, or the receptor for the virus binding, including enterocytes in the gastrointestinal tract, especially in the ileum and the colon, mitochondrial cells, and the proximal tubules in the kidneys, and the bladder cells. This is why usually patients that they have lung manifestations, that they have COVID-19, and they have lung manifestations, they might also present or experience other diseases, and it is not unusual to hear that a patient who was admitted to the ICU, he developed acute kidney injury or acute heart injury. They are very common. This is in addition to diarrhea or gastrointestinal tract manifestations, because those cells, they can get infected in addition to the lungs. It is also worth mentioning that in host cells, in addition to the ACE2 receptor, there is another enzyme, and both of them are enzyme. The ACE2 is an enzyme, and there is another enzyme which is called, abbreviated, as you can see in this figure here. It is abbreviated as TMPRSS2. And it is a type 2 transmembrane serine protease. And it's very important because it primes the S antigen, and it facilitates its binding to the ACE receptor. And now there is a treatment that we are using in the hospital. It is called Camostat, which inhibits the enzyme activity. This enzyme activity, it inhibits the TMPRSS2, and therefore can contribute to inhibiting the virus from binding to its receptor, because it inhibits priming of the S antigen on the virus, and it's binding to the ACE2 receptor. And when we talk about anti-SARS-CoV-2 antibody detection, most of the assays that are available in the market now, they detect anti-SARS